Welcome to this video entitled Otitis Media and Otitis Externa. As a way of introduction, infections of the ear are a common problem in children, but they can also affect adults. Acute otitis media, abbreviated as AOM, otitis media with effusion, abbreviated as OME, and otitis externa, abbreviated as OE, also known as swimmer's ear, are the most common ear infections. Antibiotics and vaccination programs have decreased the frequency of complications. However, serious complications may still occur. Identification, diagnosis, and management of these infections is essential to prevent permanent hearing loss, chronic or recurrent ear infections, mastoiditis, meningitis, and speech or language delay. Otitis media and otitis externa. Otitis media may manifest as acute otitis media or chronic otitis media with effusion, according to Lieberthal and colleagues in 2004. Acute otitis media has historically posed a major social and economic burden, occurring at an alarming rate of 19 million cases per year. It continues to impact antibiotic expenditures because it is the most common infection for which antibiotics are prescribed for children. In 1990, more than 25 million physician visits were attributed to otitis media, resulting in 809 antibacterial prescriptions per 1,000 visits, according to Lieberthal and colleagues in 2004. By the year 2000, the number of office visits decreased to 16 million, yet the number of prescriptions remained relatively the same, at 802 per 1,000 visits. Acute otitis media is defined as an acute onset of signs and symptoms of a middle ear infection, presence of middle ear effusion, and signs and symptoms consistent with middle ear inflammation, as shown in Table 18.1. It is the most common bacterial respiratory tract infection in children and is a result of bacteria traveling to the middle ear from the eustachian tube. Acute otitis media is most common in infants and children aged 6 months to 2 years, but the infection may occur at any age. Otitis media occurs in 60% to 70% of all children by the end of the first year of life and in more than 90% by age 7, according Hoberman and colleagues in 2002. Chronic otitis media with effusion is distinct from acute otitis media in that middle ear fluid persists in the absence of signs and symptoms of an acute infection, according to Lieberthal and colleagues in 2004. As of 2004, it is estimated that approximately 2.2 million episodes are diagnosed annually in the United States. It is most common in children aged 6 months to 4 years, according to TOOS in 1984. In fact, it is estimated that up to 50% of children will have otitis media with effusion by the first year of life and up to 60% by age 2, according to Paradise and colleagues in 1997. Otitis externa may also present in acute and chronic forms. Otitis externa is defined as an infection of the outer ear and ear canal. Acute otitis externa roughly affects 1 in every 1,000 persons in the United States, according to Osgathorpe and Nielsen in 2006. It is most common in children ages 7 to 12, but can also occur in adults, in whom the incidence declines after age 50. Otitis externa is most often associated with swimming, local trauma, use of hearing aids, and high and humid temperatures, as shown in Table 18.1. Unlike acute otitis media, in which the mainstay of treatment is systemic antibiotics, topical antibiotic therapy is usually adequate for the treatment of otitis externa. Oral antibiotics are generally recommended for patients with compromised immunity, such as patients with diabetes, those on systemic corticosteroids, or those with chronic dermatitis, according to Sander in 2001. Systemic antibiotics should also be considered for patients with recurrent episodes of otitis externa and clinical signs of malignant otitis externa. A serious and potentially life-threatening complication of otitis externa is malignant or necrotizing otitis externa, in which the infection extends to the mastoid or temporal bone. Mortality rates as high as 53% have been reported secondary to malignant otitis externa. Immunocompromised patients, including the elderly with diabetes and human immunodeficiency virus, are at the highest risk. We will now discuss the causes. Acute otitis media and otitis media with effusion. The bacterial etiology of acute otitis media in children has remained consistent over several years, according to Klein in 2009. The bacteria most frequently isolated from middle ear fluid are Streptococcus pneumoniae, that is 38% of infections, Haemophilus influenza, that is 27% of infections, and Moraxella catarrhalis, that is 10% of infections. Infections caused by Group A, Streptococcus and Staphylococcus aureus, are less common and have a mean incidence of 3% and 2%, respectively. Streptococcus pneumoniae is the most common pathogen associated with these infections. It is also the most common etiology for which antibiotics are prescribed. In fact, only up to 20% of acute otitis media cases caused by Streptococcus pneumoniae resolve spontaneously. The most common serotypes responsible for acute otitis media include, in the order of decreasing frequency, 19, 23, 6, 14, 3, and 18. Infections caused by Haemophilus influenza have a spontaneous resolution rate of 50%. Cases of otitis media in older children, adolescents, and adults are often caused by non-typable strains and can present with other serious infections such as bacteremia or meningitis. About 10% of cases are caused by type B and may be prevented by immunization. Although many cases are caused by bacterial pathogens, viruses play a significant role in the pathogenesis and course of treatment. Viral pathogens, such as respiratory syncytial virus, influenza A and B, parainfluenza, enterovirus, and rhinovirus, have all been isolated in acute otitis media cases. The presence of viral pathogens may prolong the symptoms associated with acute otitis media regardless of the completion of an antibiotic regimen. Patients should be closely monitored for these reasons. We will now discuss otitis externa. 90% of cases are caused by bacteria while the remaining 10% may be caused by fungal pathogens, according to Osgathorpe and Nielsen in 2006. And Klein in 2009. The etiology of otitis externa is different than that found in otitis media because the flora of the external auditory canal is similar to that of the skin, including Staphylococcus epidermidis, Staphylococcus aureus, Corynebacteria species, and Propionibacterium acnes. Gram-negative bacilli, namely Pseudomonas aeruginosa, may also play a role in invasive infections such as malignant otitis externa, as well as in situations in which the skin is constantly exposed to warm, moist environments, i.e., swimming. These infections may also be caused by fungal pathogens, especially in excessive humidity. Fungal infections may also occur in cases in which prolonged antibiotic courses are given for bacterial otitis externa, causing an alteration in ear canal skin flora. Up to 90% of these fungal infections are caused by Aspergillus species and to a lesser extent by Candida species. Pause the video and carefully scrutinize Table 18.1 summarizing comparing types of otitis before advancing to the next slide. Next we will discuss the pathophysiology. Let's begin with otitis media. Acute otitis media frequently follows an upper respiratory infection, abbreviated as URI, usually of viral etiology, in which the eustachian tube closes secondary to inflamed mucous membranes, according to Lieberthal and colleagues in 2004. The pathophysiology of acute otitis media is multifactorial but is mainly the result of eustachian tube dysfunction. The eustachian tube protects the middle ear from nasopharyngeal secretions, provides drainage of secretions produced in the middle ear into the nasopharynx, and permits equilibration of air pressure to atmospheric pressure in the middle ear. The structure of a child's eustachian tube differs from that of an adult's. The adult eustachian tube lies at 45 degrees to the horizontal plane and allows for secretions to drain from the middle ear to the nasopharynx. The child's eustachian tube, however, is short and horizontal. When a child develops mild inflammation or edema of the eustachian tube, the ear has difficulty clearing secretions due to the almost horizontal placement of the eustachian tube. Persistent secretions, incomplete drainage, and the absence of aeration breed an environment for bacterial growth within the middle ear, according to Pelton in 2008, and Hoberman and colleagues in 2002. The result is the inflammation known as acute otitis media. The incidence of acute otitis media is highest during winter months, which coincide with the seasonal peak of upper respiratory infections, according to Pelton in 2008. Risk factors for acute otitis media include congenital defects such as cleft palate and Down syndrome, young age, highest incidence in children below age 2, family history, and children who attend daycare or are relatives of children in daycare. The following risk factors have also been associated, however inconsistently, with an increased risk of acute otitis media: male sex, exposure to second-hand smoke, allergies, and lack of breastfeeding, according to Hoberman and colleagues in 2002. Otitis media with effusion is thought to result from prolonged blockage of the eustachian tube, which in turn causes negative pressure within the middle ear that allows fluid to accumulate, according to Pelton in 2008. These effusions may persist for several months and may result in conductive hearing loss. The presence of effusion does not always correlate to the presence of an infection. In fact, bacterial pathogens are reported in only 20% to 30% of middle ear effusions, according to Pelton in 2008. Next we will discuss otitis externa. Otitis externa is a result of inflammation with or without infection that occurs in the ear canal, according to Osgathorpe and Nielsen in 2006. Children, adolescents, and adults are all at risk for developing this infection. This condition may occur as a result of many different factors. When the skin in the ear canal is constantly exposed to wet or humid climates, the pH may vary, compromising local immune defenses and allowing bacteria and other pathogens to harbor infection. Factors such as excessive itching, using cotton balls, local trauma, swimming, eczema, use of hearing aids, chronic otorrhea, and immunocompromised states such as diabetes all increase the risk of otitis externa. Next we will discuss resistance. The increasing rates of antimicrobial resistance are a major cause of treatment failure of acute otitis media and otitis externa, according to Hoberman and colleagues in 2002, and Pelton, 2008. The increasing incidence warrants the judicious use of antibiotics. Mechanisms of resistance include alteration of drug-binding sites and the production of antibiotic inactivating enzymes called beta-lactamases. Organisms such as Haemophilus influenza and Moraxella catarrhalis can produce these enzymes, which essentially render many beta-lactam antibiotics useless. It is for this reason antibiotics that remain stable in the presence of beta-lactamase-producing enzymes must be chosen to ensure treatment success. Beta-lactam antibiotics commonly used in the treatment of acute otitis media include penicillin and its derivatives as well as cephalosporins. For infections for which beta-lactamase-producing organisms are suspected, combination beta-lactam, beta-lactamase inhibitors, such as amoxicillin clavulanic acid, should be used. A detailed discussion of treatment options is discussed in the management section of this chapter. Drug-resistant Streptococcus pneumoniae, abbreviated as DRSP, remains a threat in the treatment of acute otitis media and otitis externa. Penicillin, historically, has been the mainstay of treatment against Streptococcus pneumoniae. However, the increasing prevalence of penicillin intermediate and resistant strains has discouraged the use of penicillin. Furthermore, penicillin-resistant strains may also confer resistance to other antibiotics such as macrolides, trimethoprim sulfamethoxazole, and clindamycin. The mechanism of penicillin-resistant Streptococcus pneumoniae is the alteration of the penicillin binding site. This may be overcome by administering high-dose amoxicillin. It should be noted that infections caused by penicillin-resistant Streptococcus pneumoniae have mostly been reported in children younger than age 2. Beta-lactamase production is the mechanism by which organisms such as Haemophilus influenza and Moraxella catarrhalis develop resistance. If these organisms are suspected, specifically in the setting of treatment failure or recurrent infection, combination products such as amoxicillin, clavulanic acid and cephalosporins, i.e., sphixime, and cefpodoxime, which remain stable in the presence of beta-lactamase, should be recommended for treatment. We will now discuss the diagnostic criteria and clinical presentation. Let's begin with acute otitis media. The presentation of acute otitis media includes symptoms such as fever, atalgia, irritability, tugging on the affected ear, the tympanic membrane appears bulging, erythematous, and immobile to pneumatic otoscopy upon inspection. The diagnosis of acute otitis media requires the abrupt onset of symptoms, presence of middle ear effusion, and signs or symptoms of middle ear inflammation, as shown in Table 18.2. Middle ear effusion is confirmed by pneumatic otoscopy. Upon examination by pneumatic otoscopy, the tympanic membrane appears erythematous. Bulging may be visualized due to air or fluid behind the membrane, leading to limited or absent motility of the membrane. Signs or symptoms of middle ear inflammation include erythema of the tympanic membrane, hearing loss, and atalgia. Severe illness is defined by the American Academy of Pediatrics, abbreviated as AAP, as severe atalgia and fever of 102.2 degrees Fahrenheit, that is 39 degrees Celsius or more, according to Lieberthal and colleagues in 2004. The absence of all three elements listed above presumes a diagnosis of otitis media with effusion. Patients with otitis media with effusion are usually asymptomatic, but may complain of a full sensation in the ear. Upon examination, the tympanic membrane may not appear bulging, but air fluid levels may be apparent. Acute otitis media and otitis media with effusion require differentiation because otitis media with effusion is not treated with antibiotics because of a probable viral etiology or as the result of acute otitis media resolution. Tympanocentesis, the process by which fluid is drained from the middle ear, is recommended for recurrent treatment failure to ensure proper diagnosis of the causative organism and determine the presence of bacterial resistance. This process relieves pressure in the middle ear cavity and promotes drainage, but it is reserved for treatment failures because of the potential risk of permanent hearing loss and facial paralysis. Pause the video and carefully scrutinize Table 18.2 summarizing the diagnostic criteria for acute otitis media before advancing to the next slide. Next we will discuss initiating drug therapy. Let's begin with the goals of drug therapy. The goals of therapy for acute otitis media include symptomatic pain relief, appropriate use of antibiotics to prevent complications, and judicious use of antibiotics to prevent future antimicrobial resistance. Symptomatic pain relief can be achieved with the use of acetaminophen or a nonsteroidal anti-inflammatory drug, abbreviated as NSAID, such as ibuprofen. Antibiotics are utilized to eradicate the infecting organism and prevent complications such as mastoiditis and hearing impairment. Antibiotic use is not without limitations, such as resistance and adverse effects. For these reasons, clinicians should avoid unnecessary use of antibiotics. We will now talk about over-the-counter therapy. Acetaminophen and nonsteroidal anti-inflammatory drugs should be offered early to relieve pain regardless of antibiotic use, unless hypersensitivity exists. Local topical anesthetics such as the combination of antipyrine and benzocaine, from Allergen, may be used to control atalgia. We will now progress to observational therapy. The decision to manage acute otitis media with antibiotics is based on patient-specific characteristics such as age, certainty of diagnosis, and severity of illness. All patients with suspected acute otitis media who are younger than age 6 months should receive antibiotics. For patients with an uncertain diagnosis who are older than age 6 months, the role of antibiotics is unclear and the decision to provide symptomatic care with close observation can be made. The decision to observe and withhold antibiotics is based on the high rate of spontaneous resolution, that is approximately 80%, and overlap of nonspecific acute otitis media symptoms with viral upper respiratory tract infections. The certainty of diagnosis is based on the presence of the 3 elements mentioned before. If less than 3 elements are present, the diagnosis is uncertain. Observation is recommended for patients older than age 2 with an uncertain diagnosis or non-severe illness. Patients age 6 months to 2 years with an uncertain diagnosis should receive antibacterial therapy if the criteria for severe illness are present, while patients with an uncertain diagnosis and non-severe illness should be observed. The observation period for all ages is 48 to 72 hours. If the patient remains symptomatic after the observational period, antibiotic therapy should be considered. The technique for observational therapy is controversial. Observe with or without a prescription with instructions to fill after 2 to 3 days if symptoms persist. This decision should be based on the prescriber's assessment to whether the caregiver is likely to adhere to the plan, according to Chow and colleagues in 2008. Patients with severe illness, as defined above, should receive amoxicillin clavulanate, which is a beta-lactam antibiotic and beta-lactamase inhibitor. Amoxicillin clavulanate is active against more than 90% of strains of the 3 major pathogens that cause acute otitis media, including certain isolates of DUG-resistant Streptococcus pneumoniae. Amoxicillin clavulanate is commercially available in the United States in various concentrations of the oral suspension, chewables, tablets, and extended-release tablets. The major difference among these formulations is the ratio of clavulanate to amoxicillin. It should be noted that these formulations may not be interchanged due to the differing ratios of clavulanate to amoxicillin. The most common adverse effect of amoxicillin clavulanate is diarrhea, which is dependent on the dosage of clavulanate, according to Block and colleagues in 2006. Due to the high amount of clavulanate administered with the high dose of amoxicillin based on the standard ratio, clavulanate to amoxicillin 1:7, the ES formulation for suspension, ratio 1:14, and XR formulation for tablets, ratio 1:16, should be recommended to limit excess exposure to clavulanate and therefore reduce the incidence of diarrhea. If a patient with severe acute otitis media has a history of a non-type 1 hypersensitivity reaction to penicillin or its derivatives, the patient should receive a single intramuscular injection of ceftriaxone. This is also an option for patients who are intolerant to oral medications or if compliance is a concern, according to Wang and colleagues in 2004. Pause the video and carefully scrutinize Figure 18.1 illustrating a treatment algorithm for acute otitis media before advancing to the next slide. Next we will talk about macrolides. Patients with a history of type 1 hypersensitivity reactions, such as anaphylaxis or hives, should avoid penicillins and its derivatives, including cephalosporins. Instead, the recommendation by the AAP is to use a macrolide antibiotic, a 5-day course of azithromycin or a 10-day course of clarithromycin, as shown in Table 18.3. Macrolides are not first-line therapy due to the increased risk of treatment failure and therefore are reserved for patients with a contraindication to amoxicillin, according to Korter and colleagues in 2010. We will now discuss clindamycin. Patients who have a type 1 reaction to penicillin or its derivatives should receive clindamycin for treatment of severe acute otitis media, as shown in Table 18.3. The limitation of clindamycin is that it lacks activity against common pathogens such as Haemophilus influenza or Moraxella catarrhalis. Next we will discuss the time frame for response. The standard duration of therapy is 10 days for patients younger than age 6 or to manage severe acute otitis media, and 5 to 7 days for patients age 6 and older or treatment of mild acute otitis media, according to Lieberthal and colleagues in 2004. It should be noted that the duration of azithromycin is only 5 days if indicated. Symptoms of acute otitis media should improve within 2 to 3 days, and the patient should achieve complete resolution of symptoms after 7 days. The patient or caregiver must be counseled to continue antibiotic therapy even if symptoms resolve before completion of the entire therapy course. Pause the video and carefully scrutinize Table 18.3 summarizing an overview of antibiotics for acute otitis media before advancing to the next slide. Pause the video and carefully scrutinize Table 18.3 summarizing an overview of antibiotics for acute otitis media before advancing to the next slide. Next we will discuss treatment failure. Despite antibiotic therapy, treatment failure may still occur. Treatment failure may be due to the presence of a resistant organism to initial therapy, a viral infection that is unresponsive to antibiotic therapy, inadequate concentration of antibiotic in the middle ear, or noncompliance with the prescribed regimen. Early failure is defined as symptom persistence for up to 72 hours after therapy initiation, and is most likely attributed to viral etiology, beta-lactamase-producing organisms, or drug-resistant Streptococcus pneumoniae. Late failure is the presence of symptoms for more than 3 days after starting therapy, which is most likely due to reinfection with a new causative organism. Late failures can also be a result of a persistent resistant organism or new colonization of a resistant organism. Treatment failure requires escalation to the next step in management and is highly dependent on the initial therapy. For example, if a patient fails observation, the patient should be prescribed amoxicillin, unless an allergy is present. Follow the algorithm in Figure 18.1. Patients who fail amoxicillin clavulanate should receive a 3-day course of intravenous ceftriaxone, according to Karlik and colleagues in 2008. Tympanocentesis is a last option for patients who have failed alternative therapy. This procedure provides symptomatic relief by releasing middle ear effusion and identifies the causative organism when the effusion is cultured. Definitive therapy should be selected based on the susceptibility data reported for the identified organism. We will now look at recurrent acute otitis media. Recurrent acute otitis media is defined as more than 3 episodes within 6 months or 4 episodes within 12 months. Recurrence is most commonly due to relapse, that is infection with the same organism, or reinfection, that is infection with a different organism. Recurrent acute otitis media can be managed either by the placement of tympanostomy tubes or antibiotic prophylaxis. Specific indications for tympanostomy tube placement are the presence of middle ear effusion for 3 months or longer, permanent conductive sensorineural hearing loss, vertigo or tinnitus, severe atelectasis, or changes in the middle ear, that is adhesive otitis or ossicular involvement. Myringotomy and insertion of tympanostomy tubes improves acute otitis media symptoms by allowing drainage of the effusion. These tubes maintain a disease-free state typically in the first 6 months after insertion. However, the benefit thereafter is unknown, according to MacDonald and colleagues in 2008. Complications of tube placement include otorrhea, myringosclerosis, perforation, and tissue granulation as seen on otoscopic examination, according to Vlastarikos and colleagues in 2007. Next we will discuss prophylaxis and/or prevention of acute otitis media. Patients with recurrent acute otitis media, as defined previously, may benefit from antibiotic prophylaxis, but this concept remains controversial because of a lack of supporting evidence. If the perceived benefit of prophylaxis outweighs the risk of resistance and drug-related adverse effects, the antibiotic should be initiated during winter and early spring and continued for 3 months or until therapy fails. Amoxicillin and trimethoprim sulfamethoxazole are the most commonly used antibiotics for acute otitis media prophylaxis. The dose of these antibiotics is approximately half of the treatment dose. Refer to the dosing reference. The Centers for Disease Control and Prevention's (CDC) recommended schedule for vaccines should be followed to reduce preventable diseases. The vaccines pertinent to the prevention of acute otitis media are the pneumococcal, Haemophilus influenza type B, and influenza. Please refer to the prevention section of this chapter for a detailed discussion on target vaccine groups and current recommendations. Next we will look at otitis externa diagnostic criteria and clinical presentation. Otitis externa commonly presents with pain on movement of the auricle or tragus and a painful, erythematous auditory canal with occasional otorrhea. Hearing is usually unaffected unless pressure and fullness in the ear exist, producing occasional conductive or sensorineural hearing loss. Examination includes the ear canal, tympanic membrane, auricle, and cervical nodes. Cerumen or debris blocking the ear canal should be cleared to verify tympanic integrity. Debris usually can be cleared with a small Frazier suction tip, 5 or 7 French, or an ear curette or spoon, according to Oskithorpe and Nielsen in 2006. To rule out otitis media, the tympanic membrane must be visualized and move normally during pneumatic otoscopy in patients with otitis externa. If the tympanic membrane is bulging or erythematous, the patient should be worked up for otitis media. Malignant otitis externa is osteomyelitis of the ear canal that typically presents with fever, excruciating pain, foul discharge, granulation tissue in the ear canal, and cranial nerve palsies. We will now discuss initiating drug therapy. Let's begin with the goals of drug therapy. The goals of otitis externa treatment are similar to otitis media, which are eradicating the causative organisms and decreasing the accompanying pain. This can be accomplished by re-establishing an acidic environment in the external auditory canal or through direct antimicrobial activity. First-line management of otitis externa is to clear any obstructing debris or excess cerumen from the canal and to check the integrity of the tympanic membrane and if manifestations of the infection have spread beyond the ear canal. Otitis externa treatment consists of topical, otic drops, i.e., astringents, antiseptics, antibiotics, steroids, or combination treatments. Mild, uncomplicated otitis externa resulting from prolonged exposure to water or humidity is treated topically with an antiseptic such as acetic acid or boric acid applied to the external canal. Acute otitis externa warrants the use of an antimicrobial ototopical agent. Next we will discuss antibiotic therapy. If edema prevents application of the drops, cotton gauze saturated with antibiotic drops can be placed into the ear. The medication should be applied to the cotton wick as often as possible. After 24 to 48 hours, the cotton can be removed and the medication applied directly into the canal. Malignant otitis externa is usually treated with prolonged antipseudomonal antibiotic therapy, as shown in Table 18.4. Pause the video and carefully scrutinize Table 18.4 summarizing an overview of treatment for otitis externa before advancing to the next slide. Next we will discuss fluoroquinolones. The fluoroquinolone antibiotics, ciprofloxacin and ofloxacin, are often used to treat infections associated with otitis externa, which have ideal antipseudomonal activity. These agents are comparable in efficacy to the gold standard, neomycin, polymyxin B, with a clinical cure rate ranging from 84% to 96%, according to Doha in 2003. In addition, these agents may be more tolerable compared to neomycin, polymyxin B due to less adverse effects, i.e., stinging. The dosage of ciprofloxacin 0.3%, dexamethasone 0.1%, marketed as Ciprodex, is 4 drops into the affected ear twice daily for 7 days. This regimen should show a response within 3 to 4 days of initiation. Typical adverse events include ear discomfort or pain, ear pruritus, and irritability. Ofloxacin, marketed as Flaxinotic, is administered as 5 drops once daily, among children age 6 months to 13 years, or 10 drops once daily among children older than age 13 and adults. The addition of a corticosteroid to the antibiotic formulation is controversial. The anti-inflammatory effects potentially include reduced pain, swelling, and itching. Doha, in 2003, reported on a controlled study suggesting that the addition of hydrocortisone decreases the duration of pain by about 1 day. However, additional studies should be conducted to confirm this point. The risk of local immunosuppression and potential hypersensitivity reactions should be studied in light of potential benefits. The Flaxinotic preparation does not contain a corticosteroid. Next we will discuss aminoglycoside antibiotics. The combination product neomycin sulfate, polymyxin B, hydrocortisone acetate, marketed as cortisporin, has historically been used for otitis externa. The combination of the gram-positive coverage of the aminoglycoside neomycin and the antipseudomonal activity of polymyxin has made this combination the gold standard of treatment. The same controversy regarding the addition of a corticosteroid exists with this combination. Treatment consists of instilling 4 drops in the affected ear 3 or 4 times a day for a maximum of 10 days. The clinical cure rate of this regimen is 83% to 96%, according to Beers and Abramo in 2004, Doha in 2003. However, the side effect profile, particularly the hypersensitivity reactions related to neomycin, and possibly the preservative, is high, according to Doha in 2003. Further, ototoxicity with neomycin has been reported, although the number of reports is low and the data are speculative, particularly when the patient's tympanic membrane is intact. Pause the video and carefully scrutinize Table 18.5 summarizing the recommended order of treatment for otitis externa before advancing to the next slide. We will now discuss selecting the most appropriate agent. Regarding first-line therapy, otitis externa is treated initially with a fluoroquinolone antibiotic. The selection of ciprofloxacin versus ofloxacin depends on the formulary status of the agents as well as the clinician's experience with added corticosteroids, as shown in Table 18.5. Regarding second-line therapy, neomycin-polymyxin B combinations are considered second-line agents, primarily due to their side effect profile. The lower cost of these agents, however, warrants consideration, particularly in patients without insurance or other means of paying for the more expensive fluoroquinolones. Regarding third-line therapy, otitis externa is treated with antibacterial, antifungal and astringent and solvent agents, according to Dombera and Vossol, when a third-line medication is needed. Next we will look at special population considerations. Acetic acid 2% solution is not recommended for children younger than age 3. The concern related to the use of systemic fluoroquinolones in children is not relevant due to the minimal systemic absorption with an intact tympanic membrane. Next we will discuss monitoring patient response. A gallium scan should be performed to ensure reduction in the inflammatory process. Cleaning the local affected area is needed, but extensive debridement can be reserved until the initial antibiotic therapy is completed. We will now discuss prevention. Prevention is the key and plays a significant role in reducing the overall burden of illness, i.e., office visits, antibiotic expenditures, severity of illness. Vaccination programs have been shown to have a favorable outcome on decreasing the overall incidence of these infections, namely those caused by Streptococcus pneumoniae, influenza, and Haemophilus influenza. The introduction of the heptavalent pneumococcal polysaccharide conjugate vaccine, Prevnar, serotypes 4, 6b, 9, v, 14, 18c, 19f, and 23f, decreased the overall incidence of invasive pneumococcal disease by 69% in children younger than age 2 from 1998 to 1999 and 2001, according to Lieberthal and colleagues in 2004. Reductions in otitis media office visits and severity of illness have been observed since the introduction of the vaccine, according to Black and colleagues in 2000. The serotypes in the 7-valent vaccine when brought to the market in 2000 represented approximately 70% of the serotypes found in acute otitis media. The pneumococcal vaccine is available in 2 formulations: conjugated, that is PCV, and polysaccharide, that is PPSV, for infants younger than age 2 and children older than age 2 with comorbidities, respectively. The conjugate vaccine containing 7 serotypes demonstrated a reduction in invasive infection or disease, but few penicillin-resistant strains are included in the vaccine, according to Hoberman and colleagues in 2002. Thus, the new conjugate vaccine containing 13 pneumococcal serotypes was approved by the U.S. Food and Drug Administration in 2010 and recommended by the Advisory Committee on Immunization Practices to replace the 7-valent PCV for routine vaccination for all children ages 6 weeks to 5 years, according to the Advisory Committee on Immunization Practices, ACIP, in 2011. This vaccine contains the aforementioned 7 serotypes in addition to serotypes 1, 3, 5, 6a, 7f, and 19a, Prevnar, 2007. The polysaccharide vaccine contains 23 pneumococcal serotypes indicated for children aged 2 and older with chronic disease and not indicated in infants younger than age 2 due to poor immunogenicity. Administration of the influenza and HIV vaccines are also routinely recommended in children to decrease potential infections caused by them. The HIV vaccine is a polysaccharide conjugated protein carrier indicated for infants age 6 weeks and older. The influenza vaccine is recommended for all children ages 6 months to 18 years, but the selection of the correct formulation is dependent on the age of the patient. The two formulations are a trivalent inactivated vaccine as an IM injection and live attenuated vaccine as an intranasal administration, which is indicated in infants older than age 6 months and children older than age 2 who are not immunocompromised, pregnant, or have exacerbative pulmonary diseases, respectively. For up-to-date ACIP vaccine administration schedules, check the CDC website at www.cdc.gov/vaccines, MMWR, 2011. Next we will discuss patient education. Let's begin with drug information. To instill drops, the patient should lie with the affected ear upward and remain in this position for about 5 minutes to help the solution penetrate into the ear canal. Ototopicals should be warm to body temperature before installation to avoid dizziness. To warm the otic solution, the patient should hold or roll the bottle in the hand for 1 to 2 minutes. Counsel the patient to lie on his or her side while another person places the drops in the ear rather than the patient as a result of wide variability in self-administered dosing of eardrops. The patient should lie with the affected ear up for a few minutes after the administration of eardrops to aid passage to the medial canal. A cotton ball temporarily placed in the ear before the patient resumes an erect position will absorb excess liquid. We will now discuss nutrition or lifestyle changes. The use of hypoallergenic ear canal molds when swimming or showering is controversial for the prevention of otitis externa. Drying the ears with a cool hairdryer to aid removal of fluid after swimming may be beneficial. The patient should avoid trying to remove ear wax mechanically with cotton-tipped swabs. If the ear is very swollen, the patient can insert a wick of cotton into the ear and apply the antibiotic to the wick. It is important for the patient to avoid water in the ear until the infection clears, usually 5 to 7 days, and for 4 to 6 weeks afterward. To accomplish this, hair can be washed in a sink instead of a shower or tub, and the patient can use a shower cap when bathing. Regarding complementary and alternative medications, if the patient is susceptible to recurrent otitis externa, installation of a few drops of a 1-to-1 solution of white vinegar and rubbing alcohol before and after contact with water is good prophylaxis.
Thank you.